Yeah, thank you, Rajiv, again. And it's really a wonderful opportunity to speak with all of you. I know it's quite late today, and I was quite surprised that the team had scheduled classes at 9, and it's not only for today, it's been like this for the entire event. So I think that the people who are actually involved and the participants are really enthusiastic, and a big thumbs up to them. So, and I was actually quite taken aback that when he asked me to present on TNM. Now, as you understand, TNM means we are talking about tumor staging. So, this is really it's a very big topic, and I was happy that all the technologies from all over the country and all over the globe, they are actually interested in getting to this. Because see, the fact of the matter is that you people are the ones who are at the helm of things, and you are helping us to deliver world class and quality treatment. So if your understanding is as much updated and as much developed, it helps the clinicians to rest at peace and know that the patient is getting the best treatment possible. So without much ado, we'll go ahead. So today's talk will be around 40 to 45 minutes. I'll try to cover as much as possible. So the TNM classification was given by the American Joint Cancer Committee, AJCC, and we are into the ninth edition this year. It was from last year actually, and it keeps evolving. It keeps evolving time and again, and it even has some supplements which are added in between two major editions, when we actually need to update certain aspects, and that cannot wait for long. Now, if you look into the book per se, it's a huge book. It's a huge book. It's got plenty of images. It's got plenty of charts, flows, and diagrams. But I'll try to break it up and make it simplified for all of you so that it's very easily understandable, digestible, and palatable. So with that, we'll go ahead. So as you all know, T, N, and M. So what does T stand for? T stands for tumor, N stands for node, and M stands for metastasis. So these three things together, they form what is known as the stage of the disease. So individually, they have their own importance, but when you combine them together, they give us what is known as the stages. Now you also know that the stage of a cancer, it starts right from stage 0, and it goes all the way from 1, 2, 3, and 4. So stage 4 and stage 0 are not very much important for you, because stage 0 is a kind of condition where the disease has barely set in, means it has only started originating, and it has not achieved that cancerous and virulent form. It is usually carcinoma, which is in situ. What do you mean by in situ? In situ means that it is only within the boundaries and it has not crossed the boundary to invade into the normal tissues. And stage 4 disease is when the disease is incurable, and the disease is usually it has spread to other parts of the body. So can you go to the next slide, please? Yeah. So once we are done with this 40-45 minute discussion, what you'll be able to do is able to describe what the T, N, and M stands for, as we just started off. Secondly, you'll be able to differentiate between how the abnormal cells and the normal tumor cells, uh, how do these two differ. Thirdly, you should be able to translate a T, N, and M combination into an overall stage. As I said, 0 through 4. So we have T1, T2, T3, T4. We've got N1, N2, N3, and M0 or 1. So using these various permutations, combinations, we arrive at what is known as the stage of the disease. Also, you should be able to connect the stage with the prognosis. Like just I said, stage 0 is something which you'll never see in your therapy room. That is a disease which is yet to take its roots. That means it has just started and it has not yet breached the barrier, so that has now to become a full-fledged cancer. And stage 4 diseases usually you'll see for palliative care cases, where the patients will be visiting for short courses of maybe 1 day, 2 days, weekly, 5 days, or maybe a 10-day fractionation regimen. So this is what is a total purpose. Next slide, please. So as I said, T stands for tumor. So what is tumor? So how do you say it is T1, T2, T3, and T4? It's primarily based on the size of the tumor and its invasion into the nearby structures. It starts right from T1, goes all the way to T4. So so as you can logically understand, so T1 disease usually, which is a smaller size disease, usually maybe 1-2 centimeters. Secondly, it is usually something which is very locally confined, and the best part of this is usually when we have only a T1 disease and there is no nodal spread. That means the disease is not yet spread to the regional nodes. Like if you are talking about head neck cancers, it is not spread to the neck. Or you're talking about breast cancers, it is not spread to the axilla. If you're talking about sarcoma of the leg, it is not spread to the regional nodes which are present in the popliteal fossa, that is behind the knee, or in the inguinal area, that is the groin. So T1 disease is usually very localized, and usually the best part of it is that in most of the cases we have a treatment which is usually a single modality. That is why stage 1 stands for. In stage 1 disease, usually we require single modality. Either it can be radiation or it can be surgery alone. So in which cases can we deal with very early disease with only a single type of treatment? Let's talk about like buccal cancers or lip cancers, tongue cancers, where the disease is very small, or maybe a small T1 breast cancer, or maybe a small T1 colon cancer, or maybe a T1 lung cancer, where in many of the cases we can do away with surgery. But in some cases, like even in lung cancers, if surgery is not feasible, then you can use radiation therapy in the form SBRT. You can use to ablate the tumor. Also, you know that certain patients are quite aged and they're not fit enough for surgeries. So, can we not offer a T1 disease the chance for cure? Yes, we can. In that case, we'll be using external beam radiation therapy along with brachytherapy. So, T1, as you understand, is very localized, very small, easily treatable with a single modality of treatment. And usually, these tumors have a very good chance of success and complete cure. But as you move down the line, T2, T3, and T4, the size increases. Usually, the local structures, such as the bones, the nerves, adjacent structures, or such as the esophagus, the chest wall, maybe the adjacent muscles that are getting involved. And as you move towards T4, it becomes a very locally advanced disease where structures such as the base of the skull, maybe the vertebrae, maybe the airway pipe, that is the trachea, the esophagus, the surrounding to the heart, that is the pericardium, is involved. So these tumors are usually very locally advanced. Surgeries are very morbid. Sometimes it takes great amount of surgery to remove these tumors, and sometimes it's not even possible for T4 tumors to be operated upon, and they're treated either with radical radiation therapy or with palliative radiotherapy and chemotherapy. Now, what is N? So think about the cancer process as a tree, as a seed. So once a seed is sown and it takes its roots in the soil, well, second thing is it's supposed to develop and now distributes its seeds to the neighboring areas. It will have its own fruits, and those fruits will have seeds, and those seeds will be planted away from the tree And there we have another tree. So similarly, when the tumor grows, it sheds its cancer cells. Think about this as a cluster of maybe 100,000 or maybe 1 crore or 2 crore cells. And out of that one or two cells, they will slowly detach from the main tumor part and through the bloodstream or through the lymphatic system. Now, the lymphatic system is a system of fluids which drains the interstitial fluid and takes it back into main circulation. So from the T, that is the tumor, some of the cells they shed and they go to the N, that is the nodes. For example, a tongue cancer will metastasize to the neck nodes, right from 1 to 6, or maybe even further. A breast cancer tumor will again metastasize to the axillary nodes. It can be the same side axilla, it can be the supraclavicular area, it can be the internal mammary area. Where is the internal mammary area? It is situated inside the chest, in behind the chest bone. Or in very rare cases, it can even metastasize to the opposite side supraclavicular area and the opposite side axilla. Now let's talk about cancers which are there within the abdomen. Now, supposing if you have a pancreatic cancer or colon cancer, so where should it spread? Now, each of these organs have its own lymphatic spread pattern. So they spread to the level 1, level 2, level 3, depending on which organ we're talking about. Now, let's talk about the M. Now, M simply means can the patient be cured or not? That is, whether the disease has spread to the distant organs and structures or not. This is usually a vascular thing. That means the cells are shed in the blood, and with the bloodstream, the cancer cells get deposited within the bones, within the brain, within the lung, within the liver, etc. And there they established a separate colony of tumor cells away from the main cancers. Now, how is this different from the N? Now, when the cancer cells spread and then they spread to the nodes only, regional nodes, these regional nodes are part of the normal flow from that organ which is being affected by the cancer. But metastatic, when we talk about metastasis, they usually do not follow the anatomical spread. That is, it is spread through the blood. Nodal spread is through the lymphatic system. So this is a very basic difference. But it is to be noted that in certain cases, some of the nodes go beyond the normal anatomical spread and they spread to those areas, nodes which are far away, and even those will be counted as metastasis. So, nodal, you must understand, is more anatomical, it follows the lymphatic system. Metastasis is usually a blood-borne spread and it does not follow the usual anatomy. A brain cancer can, sorry, a breast cancer can go to the brain, a liver cancer can go to the bone, so on and so forth. So combining these three, we will get into the stage. Next slide, please. Yeah. So as I said at the outset, we have got T1 to T4, and there's also something which I said as T0. So T0 is what you call PIS, that is carcinoma in situ. But there is also something which is known as Tx. Now, what is Tx? Now, if you understand that when you're solving an equation in your school, they used to ask you to find the value of x in this algebraic equation. So x is an unknown. So that is why the Tx means T is unknown. Why do we not know unknown? Sometimes, sometimes what it happens is sometimes the disease it grows, the cancer it grows and then it spreads to the nodes or it can spread to the other organs and develop metastasis and the main cancer which had arisen due to some reason either the tumor itself could not sustain itself or because of the natural immune attack on the tumor the main tumor regresses and vanishes completely. That time we cannot say that where did the disease come from. You must have seen some cases of head neck which you treat in your linear accelerators which are written as unknown primary head neck. So that is TX. Also, it is not only confined to the head neck cancers. Sometimes it even happens in case of a spread to the liver or in the lung, with the bone, where we know that we got nodal metastasis, we got distant metastasis, but we really don't know where the tumor is and it cannot be quantified. We have means to know for sure that where a specific tumor or cancer came from. We know this because we have got something which is known as the IHC. So what is IHC? IHC is known as immunohistochemistry. Immunohistochemistry can exactly tell you that where the cancer cells originated from. All right. So, but even in those cases, because we cannot by means of CT scan, PET CT, MRI, none of the imaging or by physical examination, we can actually detect the T. That is why it is denoted as TX. So T1, so TX is where we don't know the exact description of the tumor because the tumor cannot be identified. T1S is carcinoma in situ, such as in case of cervical cancer, in case of breast cancer, in case of oral cavity cancer. The cancer has not yet taken its roots. It has not yet breached the basal membrane. Now T1, T2, T3, and T4. As you increase in size, the stage the T also increases. In T1, it invades the submucosa. In T2, it invades into the muscularis propria. T3 is invasion into the subserosa, and T4 is through the bowel wall into the peritoneum and adjacent structure. Now, if you while I'm taking you through these slides, you will see that this TNM has been explained in the context of a colon cancer. So why am I talking about colon cancer? To a radiation technologist who will not be seeing colon cancers much frequently, because it is very much easier to explain not only TNNM but also the grade and stage of the disease. So don't take this literally, but this is typically for a colon cancer. What I wanted to tell you that as that move from T1 to T4, gradually the tumor invades more and more deep and it involves more and more structures. It can be different for T1 for head neck cancer will differ from T1 for a breast cancer, which will differ from a T1 for sarcoma, will differ from a T1 of a colon cancer. So this is what the entire the philosophy is. Next slide, please. So N again. So as I told you that once the tumor or the cancer has taken its roots, slowly begins its natural progression, its natural history. So what is the natural history of a tumor? What happens is it slowly goes through the lymphatic system into the regional nodes. So what are the regional nodes? The regional nodes, as I said, is those are the natural drainage pathway of that organ. For breast cancer, it is the axilla. For lung cancer, it is the nodes which are situated within the mediastinum, that is behind the chest bone, that is the sternum. So what are these? These are N0, N1, N2, and N3. So you must understand in N0 that cancer has not yet moved into the draining lymph nodes. In N1, it is up to 3 nodes, or N2 is 4 to 6, and more than 7 we got N3. Now you must understand, as I said again, that this is colon cancer, that this description is for colon cancer, but you must understand when you're talking about N1, N2, N3, let's say for instance, let's talk about head neck cancers. So head neck cancer, N1 means few nodes are involved or nodes on the same side of the disease. Now you have a left cheek cancer, usually the left side of the neck will be involved. Now when multiple nodes are involved or opposite sided nodes are involved, it becomes into N2. But when it is N3, that means that's heavily there's neck nodal involvement. That is, there's several stations of the neck which are involved. Or let's talk in the breast cancer again. Breast cancer also, it depends on the number of nodes which are not only involved but also the levels. In breast cancer, we got level 1, level 2, level 3. So depending on the number of nodes which are involved, we usually classify as N1, N0, N1, N2, N3. So as we move from T1, TIS to T4, there's a gradual progression. Same thing from N0 to N3 as we are moving. The number of nodes usually increases and more advanced nodal levels are being involved. So this is the natural part of the natural and not the natural disease cycle in case of the cancer cells. Next slide, please. Let's come to metastasis. Now, as I said, you will be seeing metastatic patients very few and far between in your day-to-day treatment routine. Usually, as I said at the upfront, that it is M0 and M1. So, what is M0? M0 means the cancer has not yet moved to those areas which are not a part of the anatomy of the organ. And M1, it has moved to distant metastasis such as the brain, the spine, the lung, the liver, etc. etc. But there are subcategorization also within this M1. Let's leave colon cancer behind. Let's talk about lung cancer. Now we know that lung cancer patients sometimes they develop fluid within the lungs, which is known as the within chest wall, which is known as the pleural effusion. Now those pleural effusion can even have cancer cells. So this is a rare condition where only cancer cells are present within the chest wall, chest cavity fluid. That case is defined as M1A. Same thing when you're talking about colon cancer. When what is M1A? When it is spread to one site. When it is spread to two sites, it is called 1B. When it is spreading to the peritoneal surface, it is called as 1C. So same philosophy, same logic. Even when you either there is metastasis, it is 0 or 1. Now even amongst 1, we move to 1A, 1B, 1C. There is no M2. It is only M1. And this applies even to lung cancer, it applies to ovarian cancer, it applies to colon cancers. So even as we move ahead and move further and further advanced disease, even the metastasis has been subcategorized into M1A, M1B, and M1C, depending how far the metastasis has spread. Next slide, please. Okay. So this is a table where we have put in all the parameters, that is the TNM parameters for colorectal cancers. Where T is tumor, N is node, M is metastasis, starting from TIS, that is carcinoma in situ. In T1, it is involving the submucosa. T2, musculus propria. T3 is the subserosa, and T4 is involving the adjacent structures. So this table is uniform for all the type of cancers, solid cancers which you can think of. For liquid cancers or hematology cancers, the TNM or the staging is slightly different. So we'll not get into that. We'll just look into the solid cancers, such as another thing is that you must understand the classification for brain cancers is also different. It usually it is actually more, the weightage is more. We don't talk about T1, T2, T3, T4. We talk about the grade of the tumor, the size of the tumor, because there the tumor usually does not, you must understand, the patient having brain cancer, that is tumor of the brain, usually the disease, usually I'm saying, usually does not spread outside the skull. Only certain tumors such as medulloblastomas and certain ependymomas, they can spread from the brain to the spinal column, that is the within the spinal canal. But most often than not, brain cancers do not spread outside the skull. Similarly, when you're talking about hematology cancers, the classification is different. What you're talking here for TNM is only for the solid cancers. So you will be getting this chart universally when you're talking about breast cancers, you're talking about lung cancer, you're talking about colon cancer, even when you're talking about skin cancers. Skin cancers, the classification is again a bit different. The T1 is actually dependent on how, you see, skin is, as you know, skin is the largest organ in the human body because it's large surface area. So now how would you classify? You can only classify it is as you can measure a tumor as 1 centimeter, 2 centimeter, 3 centimeter. But actually for skin cancers, the classification actually depends on how deep the tumor has invaded and gone deep into the skin. On that it is dependent the T stage. N staging is actually dependent on whether the cancer has spread to the nodal areas, And metastasis, when it is widely metastasis, such as we see in case of melanomas. Melanomas are a very bad variety of skin cancers. They carry a very poor prognosis, and it has been seen that even in case they appear in very unusual sites, such as the colon or the rectum. So even then, we treat it as a melanoma of the rectum, not skin cancer, and we stage it as per the rectal cancers. Next slide, please. So you'll be getting the last slide in that last table for all types of cancers other than hematology cancers, other than brain cancers. So again, as I said, that why do we choose colon cancer for this class? We choose because we can very easily explain what is the difference between a grade and a stage. So grade, what do you mean by grade? So as you know that grade can vary between grade 1, grade 2, grade 3, grade 4. It can be a grade 1 to grade 4 brain cancer. It can be a grade 1 to grade 3 head and neck cancer. It can be grade 1 to grade 3 breast cancer. So what is this grading talking about? As we go from grade 1 to grade 3, what happens is that the tenacity, the dangerousness of the cancer keeps on increasing. That means a grade 1 tumor is more closely resembling the tumor area where it actually arose. Supposing a grade 1 breast tumor will closely resemble breast tissue, a grade 1 tongue cancer will grow closely resemble the tissue of the tongue. A grade 1 colon cancer will closely resemble the colon mucosa tissue. And as we go into that is well, it is also known as a well differentiated tumors. They're usually low grade and the cells look similar to the cells of origin. When you're going to poorly differentiated, usually the tumor starts losing its appearance of the normal tissues, and they begin to lose its characteristics. They have got abnormal structures, and usually when you look under the microscope, you see they've got a high grade disease. And the worst is the undifferentiated variety. Now, what is the undifferentiated variety? It is the worst of all the varieties, and usually it is the highest grade. And it has lost all the properties of the tissue or cells from which it arose, and it has become highly aggressive. And usually, these cancers they need even more aggressive therapies. For supposing if we talk about cheek cancer, that buccal mucosa cancer, and we've got well differentiated cancer which is T2, and a well and a poorly differentiated T2 of the cheek. My tendency would be let the T2 cheek cancer which is well differentiated, let it go, keep the patient in observation. But when it becomes a poorly differentiated, undifferentiated cheek cancer, even though it is a T2 tumor, I would be more likely to treat it with some form of adjuvant therapy, such as radiation therapy. So, for summing it up, grade means that how different is the tumor in the cell of origin, and the more close it resembles, the better is the tumor, and the more farther it is away, that is, the lesser it resembles from the tissue of origin, the worse is the kind of the tumor. Now, stage, as I said, that we have TNM, and we sum all of this up, we put it into a stage. So, stage actually means the gross anatomic extent of the disease, whether it is local, loco-regional, or it is spread throughout the disease. It is a summation of the size of the disease, invasion into local structures, into nodal structures, and as well distant metastasis. And as I said, it is a direct summation of the T and M values. It is expressed as stage 0 to stage 4, and it consistently shows the strongest association with survival. That means the stage 0 cervical cancer has got a much better prognosis. A stage 0 breast or oral cancer has got a very good prognosis as compared to a stage 3 or stage 4. So, what we talk in common clinical terms is that 5-year survival. That means will the patient survive for how many percentage of the patients will survive for a period of 5 years. So stage 0 cancer usually have got 99% or 100% survival because of cervical, oral or breast cancers. But as you go to the 5 years, you will see that the survival rate falls to as low as 5 to 10%, sometimes zero. in case of cancers of the cholangiocarcinoma in gallbladder cancers, in case of the lung cancers, or in case of grade 4 WHO grade 4 brain tumors. They have a 5-year expectancy nearing to zero. Next slide, please. So, as we said, this is just a pictorial representation. Here we go from stage 0, 1, 2, 3, and 4. 1 is carcinoma in situ, as I just said, usually is TIS, and it is N and 0 because those cancers which are in situ, they do not have the ability to breach the basement membrane and go into the nodes or to spread distantly. So that is why they got TIS, N0, M0. Stage 1 again is T is only 1 or 2 and N is usually 0. That is, it is not gone into the local regional nodes. Stage 2 is again small amount of tumor, but it is starting to spread into the nodal areas. Stage 3 is the tumor is slightly now begun to become large and it has spread into greater number of nodes or greater level of nodes. Level means the nodal levels are either closer or more distant from the main tumor. And stage 4, as I said, that no matter what the T is, no matter what the N is, it's an M1 disease. That is, the cancer has now spread to the distant organs and now it has become into a palliative case where the purpose is only to control the symptom of the patient. In those cases, usually what we do is give palliative chemotherapy or radiotherapy. So stage 1 disease, again a stage 0 disease, the chances of cure are nearing to 100%, and stage 4 disease, the chances of cure are nearing to 0%. So that is why you must understand not only the stage and the grade, but you must understand this entire TNM. This is the best overall picture which you must keep in mind. Next slide, please. So as I said, see, you should look into stage 1. They have emphasized with stage 1 and stage 2. Just grossly look. This they are talking about the stage 1 disease. Here the survival percentage in the range of 75 to almost 80%. And stage 4, the percentage is less than around 5 to 10-15%. So this is a drastic change. Just look at the figures. Colorectal cancer, stage 1 disease, survival of 75%, almost 100%, falls to 50% in case of the stage 4 disease. 5-year survival falls sharply. It falls by almost 4 times, 5 times. And in anal cancers, again, same thing. When you go to stage 1 to stage 4, the survival ranges from 77% to 55%. Even in the most, and so you see this colorectal and anorectal. These cases you must be seeing in your Linux. So even though the anal cancers they are advanced sometimes, even in stage 4, even then we can do some meaningful treatment for them, and they are usually receptive to the treatment, and then sometimes the disease response is quite good and we have got good amount of therapies where we can boost them up. But the general picture is that when the disease has gone from stage 1 to 4, the survival chances fall closer to lesser than almost 5%. So stage predicts survival, how long the patient will survive over a 5-year period. Next slide, please. So there is something which is known as phase. So as I said, that T1, T2, T3, T4, N1, N0, N0, N1, 2, 3, M0, M1. This is usually applied to because of solid tumors and does not work for brain tumors. Or it does not work in case of liquid tumors, that is blood cancers. Same thing, there are certain exceptions in case of a tumor which is seen in case of the children, which is known as the Wilms tumor, where we have a 5th stage. So what is stage 5? Stage 5 is reserved exclusive for Wilms tumors when both the kidneys show involvement at the initial diagnosis, a scenario in which the stage 0 to 4 won't capture. So this is a very rare situation, and it's a very unique situation, and it is usually seen in case of only one type tumor, that is Wilms tumor, This Wilms tumor usually you'll be seeing some cases where in the post-operative area the kidney dead. Usually we give radiation. So these are cases where if the both kidneys are involved, it is known as stage 4. This is stage 5. So this is a very unique condition, similar to I talked about the brain tumors, where we do not have nodal metastasis. Same thing, in case of Wilms tumor, we have something into stage 5. This is unique. If someone tells you there's only stage 0 to 4, you tell them yes, that's true for 99% of the cases, but in 1%, that is, there's a single case, because Wilms tumor, you have something that's known as stage 5. So there is also something known as population versus personalized staging. The TNM works well for describing population of patients, but its value for any individual has been questioned. That means you understand that even though for general lung cancer, a general colon cancer patient, you can predict that this is going to be the survival, but this is not personalized. Why? I'll tell you why. Because each tumor of two different individuals both of them having lung cancers, but both of them having stage 4 lung cancers. Even then, one person has a probability of surviving a long period of time if he's got certain mutations which can be targeted by using targeted therapy or immunotherapy. And there are other lung cancers such as stage 4, but they belong to small cell variety. And in those cases, in stage 4, the survival of 5 years is practically 0. So you understand, so it all depends not only the type of cancer, the stage of cancer, but it also depends on what is the tumor biology, what is the tumor genomics. So depending on that is why we have called something which is we are talking about this personalized staging, where we should not only just look at the TNM, but we also should look at the tumor biology. And this is a further refinement which is coming up, a direction in which the 8th edition of the AGCC has begun to acknowledge, but it is still a work in process. So even though the TNM gives you a brief over idea that what the patient is due, it does not give you the complete picture, because tumor biology is what is going to determine whether a stage 2 cancer will recur or not, or whether a stage 4 cancer is going to survive 2 years or 5 years or maybe even 7 years. Next slide, please. So, why do we need this staging? So, you must understand that we have got more than 100 countries throughout the world, and you must understand that there are more than lakhs of doctors within a country who are treating cancers. So, the TNM is basically a common language through which someone sitting in maybe Kolkata can communicate with someone in New York, and he will understand. If you say TNM for this tumor for this patient is so and so, a person sitting in New York or maybe Amsterdam or maybe in Australia, Canberra, they understand the same thing. So this is why you need a common language. Supposing we are conversing through this Google Meet, and if I were to speak in a language which is not known to you, it will be very difficult to understand what I'm talking about. So in order to make this information, to make the information very unambiguous, that is, I need to clearly and distinctly tell that what is the tumor, which stage of the tumor. So if my T varies from someone who's sitting in London, my TNM varies from someone who's sitting in London, patient seemingly would be wrong for someone who's sitting in London, because for him T1 and TNM is different. So he will see the patient from a different stage. So he will say that probably the treatment is not required, or maybe it is wrong, or we are over treating it. So that is why for cross city and cross country or internationally collaboration, we must talk in a common language, so that both people within medical oncology, radiation oncology, surgical oncology, everyone they understand. Even the pathology department, they can tell us that this is the TNM, and everyone will understand. People who are the nursing staff, if they understand whether it is T1 stage or maybe it is stage 4 tumor, they know that what to care for, what not to care for. People from the social work are very important. Patients who are stage 4 tumors, the day one, you have to kind of refer them to the palliative care, because you know that they have got limited time. Social work, what it does, it helps arrange the resources. It counsels them. It uses the local, the religious people, the leaders, the people from the church, people from the temples, people from the Gurdwara to counsel them so that they are more at peace. So, social work is something which is very much helping these patients cope with the diagnosis. And overall, the purpose is that everyone should meet and try to have a common plan for the patient. Supposing I can't have a plan for stage 3 patient and someone has a different plan, so the patient is not going to go anywhere, he's going to benefit more. So for the maximum benefit of the patients, is it is very much important that we all understand that what is the patient's prognosis, what is the patient's plan, so that we are all on the same page and we can decide what is best for the patient. Next slide, please. So, what are the takeaways of this brief talk which I've given you? If you just pick up the AGSSC 8th, 9th edition, you see it's a voluminous book. And it has got hundreds of pages, maybe 100, maybe 300, 400, 500 pages. So, it is very much, and you must understand that each of these pages are filled with tons of information. And this information is something which is just written out, just sitting over a coffee. It is each of these lines, they were debated, they were thoroughly inspected, and they were discussed, and only when a consensus was achieved, then only they decided, okay, this we can write as this. So you must understand that trying to compress such a huge volume of data into a 40 or 45-minute talk is difficult, but I have tried. And what you must take away is, see, you are going to see the patient's treatment chart, you will be seeing his records, and there you will be noticing these things, that TNM. So it should give you a fair idea that what kind of patient are you dealing with. Is the patient is going to go for a radical radiation therapy, or the patient is going for a palliative radiation therapy? Is the patient coming here even for a bone marrow transplant? For example, in some of the centers you must be having bone marrow transplant, and there we do something which is known as the total bone marrow irradiation, so that the patient is conditioned enough to take up the new bone marrow transplant. So in that cases also you must understand, see, you are there at the crux of it, you are at the center. All of our plans, whether it is doctors, all of the patients are going to go through you. So you must have a fair understanding what are we talking about, T and N. So tumor invasion, TNMR independent axis. Tumor size and invasion decides the T, how much it is spread to the nose, it decides the M, and whether it is spread to the distant sites or not decides the N. Combination of all of three will decide the stage. That means how long does the patient have to live. Exceptions being stage 5, that is Wilms tumor. Grade is not equals to stage, that is, grade is something that how far the tumor has progressed in terms of increasing its tenacity and increasing its dangerousness. A higher grade tumor is more dangerous than a lower grade tumor, and stage is something that how far the disease has spread in the body. And this stage actually decides that how long does the patient has to live. A stage 4 lung cancer is going to survive differently from stage 4 colon cancer, is going to survive differently from the stage 4 skin cancer. So this is very much important, and it is important that you people who are there at the cutting edge, you are there at the delivery point of the treatment. You must understand that what is the goal, is the future of the patient. What is the patient going to go through in his future? Is the patient is going to have a happy life, or he's got very difficult days ahead? So this gives a fair idea, and this helps you to understand and manage the patients better in terms of treatment delivery. Next slide, please. So this is how I wanted to sum up my entire 45-minute talk. So initially I thought that putting a lot of information would be difficult, but thankfully I was able to narrow it down and put in these basic concepts of what is T, what is N, what is N,
what is the grade of disease, what is the stage of disease. All grade 4 tumors are not the same. Supposing I'll give an example, where tumor has actually not spread anywhere. Anaplastic carcinoma of the thyroid, that is thyroid cancer, that is a special variety, the most dangerous variety. And even on diagnosis, when you've just diagnosed the case, it does not have to spread anywhere. It's just locally confined within the thyroid. Even then, if the diagnosis comes out to anaplastic carcinoma of the thyroid, it is stage 4 per se, even though it is not even spread beyond the thyroid, it is stage 4. So you understand what I'm saying? So it does not mean that stage 4 means it has spread to everywhere. Stage 4 brain cancer, it is not spread anywhere. That is grade 4 WHO grade 4 tumor is confined within the skull. It is present within the brain. But still it is a grade 4 stage 4 disease. So these are the exceptions, but more often than not, you must understand what is the grade, what is the stage, what we mean by T, N, and how each of these in combination will decide the stage of the disease and ultimately to lead to the prognosis. So I think I don't want to burden you much more with information, but you must understand that colon cancer stage 4 is different from lung cancer, different from kidney cancer, and all of these require adequate management. And I hope that I've been able to convey more or less. I thought that maybe I'll shrink it down to 20 minutes, but then I thought that it's better that we discuss this through. And I tried for the last 40-45 minutes to put through my point, but I'll be happy to take any questions if you have. So Rajiv, over to you.